A surgical procedure. In a world of healthcare, where compassion is paramount, there exists a place that goes beyond the ordinary. It's not just about responding swiftly in times of crisis, it's about being a beacon of hope during life's most challenging moments. It's not just about treating an illness, it's about engaging your child's imagination and turning their visit into a memorable adventure. It's not just about a diagnosis. We make it our mission to ensure that you fully understand your condition while going out of our way to simplify medical jargon. It's not just about serving meals, it's about nourishing your body and soul with delicious and nutritious food tailored to your dietary needs. It's not just about maintaining cleanliness, it's about a pristine and hygienic space that promotes healing and well-being. It's not just about performing a surgical procedure, it's about meticulous planning and executing each step with precision and expertise. Our team of doctors, nurses, and support staff work in harmony, driven by the belief that exceptional healthcare is a combination of expertise and heartfelt compassion. Welcome to Clinics, where health and care meet.
Good evening, colleagues, and indeed, welcome to Clinics, where health and care meet, and we're glad to host you again once more this evening as we continue with our weekly webinars being hosted by South Clinics Health Group, and where we invite a number of health experts in their fields, clinicians, scientists, researchers, and also academics. And this evening, it's no mean feat that we've got such a person in our midst. But before we go there, let's just remind each other that there is the CPD webinar presentations. This presentation is CPD accredited. And when you join us, when you join the webinars, when you register, please do provide us with your full details. And once you've registered, you don't have to post your details on the chat box, because we have your full information, which will pass on to the HPCSA. And for those who are with the HPCSA, you'll get your CPD points. They normally send them via email the following day. And those who are with other professional groups also submit them. You will similarly be assisted to get your CPD points when necessary. And these webinar presentations are on YouTube, and they're streamed live on YouTube. So you're at liberty to go and check the presentations the following day. If you missed something, or if you're not able to join any of our webinars, do like us on YouTube, and then you'll get the links to the presentations, and you'll be able to watch the presentations. There are a number of you who have asked that if they missed the presentations, if they could watch the YouTube on the following day or any other time, and if they will be getting CPD points. We're working on that to see if when you watch it on YouTube, when you've missed it, if you'll be able to get CPD points. They will have to find a way of making sure that we are able to provide you with that service. But this evening, we are excited to have Dr. Tina Low, who's a specialist, a pathologist at Ampath Laboratories, and she specialized in clinical microbiology. And after qualifying with an MSHB from University of Cape Town, she worked in the pharmaceuticals industry for about 8 years, where her passion for antimicrobials and infectious diseases began. And this led to her to a DTMNH and also an MMed microbiology and a fellowship in pathology and microbiology with the CMSA through Wits University. Dr. Low is passionate for teaching others about microbiology in his spare time. You'll find her doing things with her two Yorkshire terriers. You've seen, I think, those who are watching that on the profile picture, that we've got one of these little puppies. And we're excited that to have her, and she does rounds at clinics, health group, wards, and other places where she's got contacts, whether she's got an opportunity to provide her teaching skills. And we're excited that she is able to join our specialists, and we want to invite all other specialists, pediatricians, physicians, do please join the ward rounds. We are currently at September once a month, and also at Dr. SK. We'll be starting at Naledi and Victoria, and hopefully Butselong and other hospitals. And any of you colleagues who are outside the clinic health group, I'm sure you're welcome to join during those ward rounds. Just contact us. We'll arrange for you to know which days so you can learn about antimicrobial stewardship. So this evening, Dr. Lowe will be talking to us about microbiology lab results, how to sort through the junk. And Dr. Lowe, thank you very much for accepting the invitation, and we are eager to listen to you and how to navigate our way through the junk. Thank you.
Thank you so much, Dr. Bieler. I appreciate the invite.
Pleasure.
All right, so let me get going. All right, so I know that microbiology lab reports can be quite daunting, so I just thought I would go through various of the lab reports, and also just guide you on how to actually interpret them and work through what's significant and what's not. I see my slide is not progressing. Let me just have a look.
Hi, Doc. If you can maybe click anywhere on the slide.
I am.
Try moving. Try moving it now.
Okay, I've got it.
Perfect.
All right. Okay. So just some disclosures that I have had, a sponsorship to, congresses, and I've had some speaker fees. All right. So this is what I'm basically going to go through. Just a little bit about, specimen collection and selection and collection. The basics, MCNS, what does it stand for, and what is involved, and then through the various culture sites, and last but not least, just a couple of the septic markers. And I'm hoping to get that done very quickly in the next 45 minutes. All right, so let's look at specimen selection and collection. Well, basically, selecting and collecting a specimen is the single most important step in the diagnosis of an infectious disease. So the general rules that apply to all specimens are, firstly, you've got to send enough specimens. So the quantity is critical. It needs to be representative of the infectious process. So if your patient is coughing, don't send a urine. All right, avoid specimen contamination by always using sterile containers and using aseptic technique. And also very important, always send specimens before administering antibiotics, obviously where that's possible. ICU, obviously that's not always the case. And then obviously prompt transportation to the laboratory. So those 5 points are critical in getting the right organisms from the right site. So let's just start with the basics of MCNS. So M is for microscopy. And just refreshing your memory on what's the gram stain. So anything that's purple on a gram stain is gram positive. And then they determine whether they gram positive cocci in clusters, gram positive cocci in chains or pairs, or gram positive bacilli. So your Staph aureus will be your gram positive cocci in clusters. Your pyogenes, strep pyogenes will be in chains. Your strep pneumoniae will be in pairs. Sometimes they've got a capsule. And then gram-positive bacilli, the clinically important one would be Listeria, but you also have to think of Bacillus and Corynebacteria there. Then your gram-negatives, the important ones are, for instance, Neisseria meningitidis, which is gram-negative bacilli, or gram-negative diplococci, Haemophilus, Klebsiella, E. coli, and all of the Enterobacteriaceae are gram-negative bacilli. And we don't really say, whether they're thin or short or whatever, but for a microbiologist, when we look at the gram stain, we can already imagine that it's, this is a Haemophilus versus this is an Acinetobacter. There are ways to actually determine that. But on the actual laboratory report, it'll just say gram-negative bacilli, and then you need to think of these organisms. Right, now the C of MCNS is, the C is the culture, all right? So once we've got our specimen, we plate it out onto various different agar plates. all right, and incubate them, and then we wait for these tiny little colonies and organisms to actually grow. So once we've actually got growth, how do we know what that organism is? Well, these days we use something called MALDI-TOF. Now, MALDI-TOF basically stands for matrix-assisted laser desorption ionization time of flight mass spectrometry. Very long word. You never have to remember it, but we basically call it now MALDI-TOF. So if you've ever heard a microbiologist or somebody talking about MALDI-TOF, that's when we take a tiny colony off those agar plates, and this is how we identify it. So what we do is we basically take a tiny amount of those colonies, we put this onto a target plate, and now this little plate is the size of a microscope slide. I'm sure you've all, familiar with that from your days at varsity. So you put the tiny colonies on this target plate. We overlay it with something called matrix, which basically solidifies it and keeps it in place. And then we basically once we've, put everything on this tiny target plate, we put it into the mass spectrometer, and then there's a whole automated measurement. And I'm just showing you the two that we use here at AMPATH. We use the bioMérieux Vitek MS and the Bruker MALDI biotyper. And basically what that involves is, you can see there's your plate. You've taken your colony off, you've put it onto your target plate, and then you've put it into your MALDI-TOF machine. So what happens in the MALDI-TOF machine is that there's a pulsed UV laser that hits that plate. It evaporates the little bacteria and components of the bacteria and the matrix. And the matrix that you put over basically ionizes all the molecules. And then basically they are accelerated in an electric field, and they enter this tube, which is called the time of flight tube. All right. And based on their charge and their weight, basically you end up with a profile here, as you can see on the right, of the various different bacteria. And this then gets compared to a database that we have paid for from the company that, has given us or sold us those machines. And that way we are able to now identify which organism we're dealing with. So this, for each organism, will take under 1 hour. Whereas in the olden days, it used to take over 24 hours, and we used to have to do little chemical reactions. But now we do everything by MALDI-TOF. So the idea of an organism is quite quick. The slow part is telling you what the sensitivities are. All right, and that's the next thing on the basic concepts, the MC and S. The S is the susceptibility testing. Now, this can be done using various methods, but the 4 commonly used methods in the microbiology lab are disk diffusion, which you can see there in the picture, which we use for things like urines and pus swabs, the less significant samples. We've got antibiotic gradient strips, which is called e-tests, and these are able to give you the exact MIC, or minimum inhibitory concentration. Then most of our samples go on automated systems or Vitek, and you can see each little well here is a different antibiotic at a different concentration, and that helps us determine, whether the organism is sensitive to an antibiotic. And then last but not least is broth microdilution. And this is quite time consuming and labor intensive, but there are certain antibiotics that we can only test in this way. And one would be colistin. That's why colistin takes so much longer than the other antibiotics to test. And we also use this a lot for the antifungals as well, especially on critical sites. So those are the 4 most commonly used methods for susceptibility testing. So what are we looking for when we're testing susceptibility? Well, we're looking for the MIC of an organism, and that is basically the lowest concentration of an antibiotic or antifungal that can inhibit the visible growth of an organism. And this is done under standard conditions with a standard inoculum. And this is the most important pharmacodynamic parameter that quantifies whether an organism is sensitive or resistant to an antimicrobial. So we at AMPATH use UCAST to determine our susceptibilities. So basically on your antibiogram, you'll see 3 letters appearing, S, I, and R. Now with UCAST, S means susceptible, sensitive. I means it's susceptible, but at an increased exposure, meaning a higher dose. And R means resistant. Now, in the past, I used to mean indeterminate. And the reason, one of the main reasons that, AMPATH has moved to UCAST is because I being indeterminate, what does that tell you as a doctor? You have no idea what that means. Can I use it? Can't I use it? And so UCAST has moved away from that. So the I in UCAST means it's susceptible, but you have to use a higher dose in order to treat the infection. So that's some of the basic concepts. Now, as an example, showing you what S, I, and R means, this is the distribution of strep pneumoniae MICs against benzyl penicillin. And this is a database as of the 27th of June, 2023. And in here, there were a lot of observations, 15,000 plus observations. Now, you can see here that if your antibiogram said susceptible and it said S for sensitive, that means the MICs are in this range here, the average range, and you can see the bell curve. If it showed I, which means susceptible but an increased dose, you can see this is where the MICs will lie. And if it's R, well, then it's resistant. And so this is just showing you how we determine this in the laboratory. Right, let's now move on to actual cultures and how you interpret them and how you can help us in making sure that we get a result that actually assists you. So now blood cultures these days, okay, are done in automatic, continuously monitoring systems. And remember that they must always be collected using an aseptic technique. Unfortunately, having done multiple rounds in numerous hospitals, I know that this is not the case. An aseptic technique does not mean you take a little alcohol swab, dab the vein, stick a needle in, and try and get the blood out and inject it into the bottle. You have to use a proper technique, which involves using chlorhexidine, drying the site, doing wearing an apron, sterile gloves. And I know that this doesn't actually happen. And that's why we get so much blood culture contamination in many, many hospitals. So when you're looking at your blood culture result, you need to be able to differentiate between a bacteremia, being a true infection, and contamination. Unfortunately, as I said, contamination is a huge problem, and all hospitals should aim for a contamination rate of less than 3%, but I know for a fact that that isn't reality. So we need to look at the organisms that commonly are reported on our blood cultures and are frequently contaminants. So you can have skin flora, and these are your coagulase negative staph, Corynebacteria, Actinomyces, Micrococcus, Strep viridans, Cutibacterium acnes. And then you also get environmental flora like your Bacillus, Moraxella, Aerococcus. I didn't put it here, but Neisseria, the non-meningitidus, non-gonorrhea species. And they also occur frequently. And these are often colonizers of the respiratory tract. Patients sneeze, they're in their saliva, it gets onto the skin. And without proper aseptic technique, we often culture these on blood culture. So virtually all blood culture contamination occurs during collection. It's not in the laboratory, it's not at other sites, it's during collection. So not only do us as laboratories need to really train our staff to do the correct job, but also the ICU staff and the nursing staff in hospitals need to be trained to do the correct thing. So unfortunately, in South Africa, in many hospitals, our contamination rate is more than 3%, unfortunately. All right, blood cultures, as I said, it's all automated now. All right, and I'm sure if you've ever looked at the bottom of a blood culture bottle, you'll see that there's this a CO2 sensor bonded to the bottom of the blood culture bottle. It's separated by a semi-permeable membrane, and it's impregnated with water when they actually make the bottles during the autoclaving procedure. Now, it's a unidirectional membrane, so CO2 can only pass one way, from the broth into the actual sensor at the bottom. So when organisms are multiplying in that broth, they generate CO2, it diffuses across the membrane into that sensor, it dissolves and generates hydrogen ions. And what this does is the hydrogen ions interact with the sensor and they turn it from green, which is negative, to yellow, which is positive. Now, in the olden days, we used to have to visually do this and see has it turned or not. But now we've got this LED that actually every 10 minutes shoots a light at the bottom of that bottle and will see if this sensor is changing from green to yellow. The second it detects a change, the bottle is ejected from the machine and immediately the laboratory staff are alerted. They take the bottle and they immediately do a gram stain. And obviously that is helpful in letting you know early what we're possibly dealing with. Also important to know that you're using the correct bottles. So with the Bacti Alert system, there are 5 commonly used bottles. The blue and the purple top, all right, that's your standard aerobic and anaerobic, should only be used in patients that are not on antibiotics, all right? If your patient's been in hospital for a while and is on antibiotics, only the green and the orange top bottles should be used, and impedes the yellow one. And these 3 last ones all contain something called FAN, which stands for fastidious antimicrobial neutralization. And basically, you'll see if you look at those bottles when you go to work tomorrow, you'll see there's these tiny little beads called adsorbent polymetric beads. And what they do is they neutralize any antibiotics that could be in the blood. Not all antibiotics, obviously, but they try and neutralize as many, as possible. You can see here specimen type. For the top 4, it says you can put blood or a sterile body fluid in these bottles. So it's not just for blood. You can put in pleural fluid, peritoneal fluid, joint fluid. You can put those types of fluid also in the blood, in these blood culture bottles. Important to also notice is here on the side of the bottle is a fill window. This is most important for the nurses and the people taking the blood, so that you can see that you put an adequate amount of blood or whatever fluid you're putting in there into the bottle. Now, the important thing with blood cultures is the volume that you actually send to the lab. The volume of blood is the most important variable in actually recovering pathogens from patients with bloodstream infections. And as you can see here, for adults, you need to send 20 to 30 mils of blood per culture set. And sometimes it requires 2 or sometimes 3 bottles. Now, if you look at this graph here, if you only send, this is an adult, one of those yellow pediatric bottles with 4 mils in it, you'll see that your chance of positivity is less than 10%. And yet we see this time and time again, adult patients, they just send 1 little yellow top tube. This is completely inappropriate and should never be done. So a minimum of 20 to 30 mils of blood is needed if you really and truly want to find out what organism is causing a bacteremia in your patient. As you can see here, 15 or 20 to 30 mils, your positivity percentage is approaching 70%. And that's why so many times our patients are septic, we just don't get enough blood to diagnose the organism that's causing the sepsis. Children is a different situation. Here it's all weight-based. So if you've got a tiny preemie, you can only send 2 mils because, any more than that and you're actually going to be causing hypervolemia. But once your child is over 36 kilograms, you must be sending adult volumes of blood. So this table basically just guides you on the volume you need to send per weight of the baby. So let's look at the commonly isolated organisms. You've all seen coagulase negative staph. Your staph epidermidis, your staph hominis, hemolyticus, caprae, saprophyticus, and even new names which you've never heard of before. So it's important to know that coagulase negative staph are normal skin commensals and they are frequent blood culture contaminants. The exceptions are premature babies, and low birth weight babies, patients with central lines or implantable devices, severely neutropenic patients, and patients with infective endocarditis. If your patient doesn't fall in this group, most likely the coagulase negative staph is something you should ignore. But there are some things you can look at to ascertain, is this or isn't this significant? You can look at how long did it take for the culture to become positive. So on the lab report, it does say within 1 day, within 2 days, within 3 days, within 4 days. So if it's in less than 1 day and it's on all the cultures you sent, so 4 out of 4 cultures are positive and all less than 1 day, that is significant. And you then need to look, where is it coming from? If it's more than 1 day and it's only positive of 1 out of 4 blood cultures, in all likelihood, that is a contaminant. All right. Also, look at the CRP and the PCT. If you've got a staph epi, even if it took more than 1 day, and your CRP is 10, 25, even 40, it's guaranteed that that's a skin contam, and then you don't need to treat it. Let's look at some significant organisms. So let's look at Staph aureus. Staph aureus is never considered a contaminant on blood cultures. Unfortunately, the source is not apparent in more than 40% of individuals, which is a problem. But when you see Staph aureus on blood culture, you need to always do investigations for the source and also look for metastatic spread of the Staph aureus. So you need to look, is it coming from the central line, intracardiac device, infective endocarditis, skin and soft tissue infection, osteoarticular infections, pleuropulmonary infections, or abscesses. Horrible thing about Staph aureus is even in this day and age, it has a mortality rate around 25%, even though we've got fantastic antibiotics. And that's because we don't look for the source and we don't look for the metastatic spread of it. With Staph aureus, you have to repeat blood cultures every 2 days once you've cultured it. And this is necessary to document that you've cleared it and to also establish the treatment duration. So if you've got an uncomplicated bacteremia, meaning you clear it after your first culture, so your next culture, it's negative, you've cleared it, you've controlled the source, you only need to treat for 2 weeks. But if you have continuous growth of the organism, you've debrided, but you're not getting on top of it, it becomes a complicated bacteremia. And then we have to treat for 4 to 6 weeks. And sometimes the undertreatment is where the problem lies and the cause of the high mortality rate. Many countries have adopted this bundle approach for Staph aureus bacteremia, and there's 4 components. So if you have Staph aureus on a blood culture, the first thing you do is you get an infectious diseases consultation. We know that we don't have huge numbers of ID consultants in South Africa. If you can't get an ID consult, call your microbiologist. We are always willing to help. Secondly, you need appropriate antibiotics. And when I say appropriate, if you've got a sensitive Staph aureus, sensitive to clox and cefazolin, vancomycin is not an appropriate antibiotic. You need to change to a beta-lactam. You have to have source control, removing any foreign materials, debridement if that's necessary, and then repeating the cultures until your blood cultures become negative. So these are critical when treating a Staph aureus on bloodstream. Oops, it's not moving. There we go. Right, your gram-negative bacteria. So the Enterobacteriales, which is your E. coli, Klebs, Pneumos, Enterobacter, Serratius, Morganellus, all of those, and Pseudomonas are never contaminants on blood cultures. There are a couple of gram-negatives that are sometimes contaminants, and this is usually related to contaminated fluids or just colonizing the central lines. And these are Stenotrophomonas multifilia, Acinetobacter, and Burkholderia cepacia. An interesting thing is on many rounds that I've done with Prof. Richards, he'll say that his patients in the ICU die with Acinetobacter, but not from Acinetobacter. But that's not always the case, obviously. Now, if you look at your gram-negative bacteria, you can either have a primary bacteremia where you don't know where the source is, And in the ICU, this is responsible for about 7 to 22% of gram-negative cases, bacteremia cases. And they postulate that it's due to translocation from the gut, due to, for instance, ischemia, low blood pressure, and therefore, increased translocation from the gut due to poor, blood flow. But the vast majority are due to secondary bacteremia. So in those situations, you have to look for the source. So clearly, the first thing that we always need to look at central lines, often pneumonia, UTIs, intra-abdominal sepsis, and skin and soft tissue, your decubitus ulcers, your wounds, and those kinds of things. Once you've got a gram-negative bacteremia, your duration of treatment is about 7 to 14 days if you can remove the source, i.e. control the source. Could be shorter if you're using PCTs and you know that it's definitely, like, for instance, a central line, you've removed it, you've got source control, and your PCT is, responding. So that's your gram-negative bacteria. Candida is also never considered a contaminant on blood cultures. You always have to investigate the source, which is often, most commonly, central lines or abdominal collections from abdominal pathology. But you always also need to look for metastatic infections, like with staph. Have you now got an infective endocarditis? Has it seeded out into the eye and you've got endophthalmitis? Are there organ abscesses, liver, spleen, bone, and kidneys? These things you have to investigate. Like with staph, you need to repeat blood cultures every 2 days until your blood cultures are negative. And this is important because if you don't do this, you won't know how long to treat for. Because the treatment of Candida is 14 days after the first negative blood culture. So if you don't know when the blood became negative, you might undertreat. In neutropenic patients, you need to treat for 2 weeks after resolution of the neutropenia and the last positive blood culture. So that was blood. So let's now move on to catheter tips. All right. So now the isolation of any organism on the tip of an intravenous indwelling catheter can mean two things. It can either mean just colonization, and that's not significant and you don't have to treat it. Or it could mean that it's the source of a central line associated bloodstream infection. So if you're going to send a catheter tip for culture, don't send it without an accompanying blood culture, because you need both to determine, is this colonization or is this the source of eclampsia? So if you isolate it on a blood culture and you've got, on a catheter tip, and you've got no blood culture, you have no idea whether that organism is significant or not. Sometimes it does help looking at the colony counts. So if your colony counts are less than 1,000 colony forming units, it could be contamination, could be early signs of colonization, but you just don't know. You need to send a blood culture. And on that subject of tips, it is always inappropriate to send a urine catheter tip, pigtail tip, EVD tip, or endotracheal tube tips. The guidelines for those tips and the colony forming units have not been established, and it's impossible to know because all of these could just be colonizers. So the laboratory really should reject all specimens that are not intravenous indwelling catheter tips. But I know we don't. So we do, if you want to send another tip and there's a reason for it, it's always good. Just phone your microbiologist and explain. And then maybe they can also, tell the laboratory what you're actually looking for. Let me just show you an example of a catheter tip result. You can see here it was this was a CVP catheter tip. It's growing a Candida auris. It's got greater than or equal to 1,000 colonies per mil, and we're growing a Candida auris, and that's the colony count. Now, I'd ask you all on the line, is this significant? And a lot of people say, oh, it's Candida auris, it has to be significant. I'm starting in echinocandin straight away. The answer is that's actually not the case. All right. So why was the catheter tip sent for culture? Well, I find in numerous ICU, this is just routine practice when CVPs are removed or Quinton lines are removed. And this is completely wrong. We should not be when we remove a central line, we should not just send it routinely for culture. We should only send it when we're suspecting that the patient has an infection from that tip. So there I say, why was the catheter tip sent for culture? Okay, it was sent because a eclampsia was suspected. That's perfect. What do you look at next? What organism is growing? It's a Candida auris. What is a colony count? It's a very high colony count. It's more suggestive that this is significant. But was a blood culture sent? If no blood culture was sent, then the first thing you need to do is to send blood cultures so we can correlate. And if it's a Candida, you could potentially send a fungitel, which might be a bit quicker. Then what grew on the blood culture? If the blood culture is completely negative, your patient is stable, and you've just got this growing on a catheter tip, then there is no need to treat. But we need to move away from ICU sending catheter tips just because a central line is removed. Just a take-home message for everyone. Right, let's now move on to CSF. Just, CSF, I mean, if you grow something on a CSF specimen, the majority of times is significant. Just to note though, white cell counts are different based on age, and this doesn't appear on the lab reports. But in a neonate or a tiny little one, you can have up to 30 cells and that can still be considered normal. In children under the age of 4, up to 20 cells is considered normal. Once puberty and older, obviously anything more than 5 cells is considered significant. You guys, I'm sure know all this. This is just for, refreshing your memory. But what a lot of people don't know is how to correct your white cell count and your protein values if you've got a very bloody tap. So if you've got a very bloody tap, all right, and you look at your red cell count, okay, and you see that it's really high, you basically subtract 10 milligrams per liter of protein for every 1,000 red blood cells. Once it's over 3,000 red blood cells, you can no longer trust that protein value, unfortunately. Then for those bloody taps, you subtract 1 to 2 white blood cells per 1,000 red blood cells that you see on the cell count. And you might then put your white cell count back into the normal range. So this is just something that's important if you see a really bloody tap. Let's just look at amounts of tubes being needed in the lab. These days, we get requested so many tests on the CSF and they send just one tiny little tube. You need to remember that we need about 3 to 4 tubes of CSF for all the diagnostic studies, all right? Unfortunately, the first tube has the highest potential for contamination because that's the one that went through the skin and it might collect normal skin commensals. So it's important to rather fill your glucose tube, your gray top, with that first, the first one that after you've got the lumbar puncture done, fill your glucose tube, and then after that, fill all the other tubes, and those tubes can be sent to the microbiology lab. Everybody still asks, not everybody, but huge numbers of people are still requesting bacterial antigen testing on CSF. According to international guidelines, it is no longer recommended and shouldn't even be ordered or offered by the laboratory. But obviously that's in a perfect world. In developing or third world countries, we still offer antigen testing because it's so much cheaper than the alternatives. But it is an outdated test with terrible sensitivity. So you should rather request a bacterial PCR or a normal PCR that detects all sorts of organisms. So we've got your BioFire, your QIAstat that can detect all the common bacteria, the common viruses, and can also detect Cryptococcus. So there are alternatives, and strangely enough, that bacterial antigen testing uses so many mils of CSF. It's actually far more efficient to request a PCR if your patients are obviously on a medical aid, because you'll get a lot better sensitivity with that result. Just to mention TB meningitis, there's very poor sensitivity for PCR on non-respiratory specimens, including CSF. So you should always request culture, TB culture, on your CSF. And if there's very little CSF, rather request culture than a PCR. I know you've got a long wait to get a result, but it is far more sensitive. And even when you do request culture, the sensitivity for TB meningitis ranges between 25 to 70%. But you can increase the sensitivity if you send large volumes of CSF. So if you're strongly suspecting it, please send as much CSF as you possibly can. Right, that's enough of CSF. Let's move on to respiratory tract cultures. Very difficult to interpret. So when you're looking at your respiratory specimen cultures, you need to take the following into consideration. The quality of the specimen, and I'll tell you how to work out the quality, the quantitation of the growth, and always correlate clinically and radiologically. Are they tachypneic? Are they SATs dropping? And what does that X-ray look like? We get so many cases in the hospital that I can't speak for outpatients, but in the hospital where the chest X-ray is completely clear. The patient is not at all distressed, but because they spiked a temperature, they sent a little bit of everything, a sputum, a urine, a blood culture, a tip, whatever. And they grow something and immediately they get treated. And this is just a colonizer. So we have to look at these things when we're interpreting our respiratory specimens. If you send a good quality specimen, all right, 73% of the time you will detect the true pathogen. If it's a shocking or low quality specimen, you're only going to detect the true pathogen there in 36% of the time. Very importantly as well is Candida does not cause pneumonia. It is a respiratory colonizer, and unfortunately too many people reflex to echinocandins or amphotericin B based on a respiratory culture, and this should not be done. When you see Candida on a respiratory culture, even if it's a tracheal aspirate or bronchiolar alveolar lavage, it is a colonizer. It tells you your patient is colonized. It does not tell you your patient has got pneumonia from that organism. So let's look at how you work out the quality and quantity and all the rest. So the quality of the specimen, okay, there is something called the Bartlett's grading system for sputums, very complex, but the nitty-gritty of it is you need to look at the number of neutrophils versus the number of epithelial cells. So if you've got virtually no polymorphs and you've got lots of epithelial cells, which basically comes from the mucous membranes of the mouth, this indicates that your sample contains or consists of saliva. And yes, it might grow a Haemophilus or a strep pneumonia, but those could just be colonizers. So if you've got a poor quality specimen, you should not trust those results. You should rather send a repeat specimen. If, however, you've got numerous polys, very few scanty epithelial cells, and you see there that the gram stain said, gram-negative bacilli, and you grow copious amounts of an E. coli or a Klebs, then you know that that's a good quality specimen. You'll see often reported in the sputums, it says the presence of greater than 25 epithelial cells indicates a sputum with oropharyngeal contamination. And in most countries, this is a grounds for rejection of the culture. But in South Africa, we don't reject specimens. This is, we don't have NHI or, how it is in the States. So we still continue to culture it, but letting you know that if there's more than 25 epithelial cells, in first world countries, they reject that specimen and they insist that you send a better quality specimen. And then if you actually do the whole Bartlett score, you'll see that a Bartlett score of less than 0 also indicates zero inflammation or contamination. So that's your quality of your respiratory sample. Now we need to look at your quantitation. Is it heavy, moderate, light, or scanty growth? So a true pathogen on a respiratory specimen, you will find it reported as a moderate or heavy growth. When you see it saying scanty, you need to rethink it, look at the quality again, and think this could actually be a colonizer. And then last but not least, even if your quality is fantastic, your quantity is fantastic, if your chest X-ray is completely clear and your patient has got no signs of respiratory distress, again, this could just be a colonizer. Let me show you two examples. Let's look at this one. All right, this is a sputum. Let's look at the quality of the specimen. Less than 10 pus cells per low power film, greater than 25 epithelial cells per low power film. You can already see this is saliva, or, it contains salivary contamination. Let's look at the quantitation. Only scanty growth of an organism that very rarely in an outpatient setting or long-term care facility would cause a pneumonia, Acinetobacter nosocomialis. This is a colonizer. But look at the sensitivities. It looks like it's XDR, and the only option you've got is tigecycline or colistin. So what do you do next? You correlate with your chest X-ray. This was the chest X-ray. Beautiful lungs. Why would you treat now with colistin or tigecycline? This patient doesn't have pneumonia. So in this situation, there's no new infiltrates. This is guaranteed to be a colonizer. Next example, this is a tracheal aspirate. You'll see there, a lot of pus cells, very few epithelial cells, just gram-negative bacilli on the gram stain, and we're only growing a gram-negative, and it's profuse growth. Is this significant? Well, we still don't know. We still need to look at the X-ray. Here's the X-ray for this patient, and you can see there's a new infiltrate. So this is most definitely a pathogen and needs treatment. Unfortunately, it's a super resistant one. And in these situations, it's always best to call your microbiologist and ask which is the antibiotic which is going to penetrate that site the best. And we like to have these discussions with the doctors. Just to remind you now, for viral pathogens, the only way to detect them these days is with molecular testing. It's, the best way to go. We've got various multiplex panels, either just for viruses or viruses plus your atypical bacteria, or a really abbreviated panel which just looks at your potentially treatable options and the ones causing the most severe disease. But remember that not all positive results indicate current infection. They can also indicate colonization. So you also have to correlate clinically. There's a new, it's not new anymore, but a lot of people don't know about it. It's another PCR, which is most applicable for patients in ICU. Now, this PCR is called the BioFire Film Array Pneumonia Panel. It can detect 18 bacteria, 7 resistance markers, and 9 viruses. It only takes an hour to run. That's from the time the specimen is in the lab, all right? And it can even quantify or semi-quantify to tell you how many DNA copies are actually present. And I'll go into the details. It has some limitations. Firstly, it can't detect SARS-CoV-2, and it can't detect some nosocomial pathogens like Stenotrophomonas multifilia, Aspergillus, and Pneumocystis. And the other thing is you don't get susceptibilities on these PCRs. But it is awesome for patients in ICU that are on multiple antibiotics, and you are very unlikely to grow anything because they're on multiple antibiotics. So these are all the bacteria it detects. And you can see these are all the common ones you're looking for in your ICU. And what's really nice is you can detect if it's got a resistant mechanism. So it can detect MRSA, it can detect if it's an ESBL, and it can detect if it's a CRE. And then in addition, it looks at all the common atypicals and then the common viruses. And most of the medical aids will pay for this in an ICU. So if you failed on sending a tracheal aspirate and you can't stop any of the antibiotics, you can request this BioFire pneumonia panel. Right, let's go on to urines. That's also a really difficult one where there's a lot of overtreatment. So let's look at what is considered positive urinalysis. Well, you need more than 10 pus cells on the cell count, okay? So you need a pyuria. If you've got a positive pyuria, you should have a positive leukocyte esterase. If you've got positive leukocytes and your leukocyte esterase is negative, it could be that they're not polymorphs, that they're mononuclear cells, and that could mean that it's something completely different, like an interstitial nephritis or something like that. You should also look to see if the nitrites are positive. Nitrites are not always positive with every organism. They're only positive with certain bacteria, and that's your E. coli, your Proteus, and your Klebsiella. but I have seen it sometimes positive with Pseudomonas and a couple of other organisms. A positive culture or significant bacteriuria. If you've got no catheter, you need more than 100,000 colony-forming units. If you've got a catheter, even as low as 10,000 colony-forming units is considered significant. But in the lab, we never know because it never tells us on the lab where the sample was taken from. It's easy to tell if a sample was poorly collected or contaminated with, normal flora. You'll see that there's scanty or no leukocytes. There'll be millions, or when I say millions, there'll be numerous squamous epithelial cells, and often you'll just get mixed growth. And the report says multiple bacteria isolated, and we don't even go any further. There's another situation to look out for, and that's something called sterile pyuria. We've got lots and lots of pus cells, and the culture is always negative. Major cause of this is the fact that the patient's on antibiotics. So if a patient's on antibiotics, they are usually concentrated in the urine and it prevents growth. But don't forget possible TB, interstitial nephritis, vaginitis, other STIs, and also non-infective causes like recent surgery or foreign bodies in the urinary tract. Like merely having a catheter in place can give you a pyuria, and then also kidney stones. This is something, especially in the outpatient setting, which is overtreated, and that is asymptomatic bacteriuria. So what is bacteriuria? That means you've got more than 100,000 organisms on culture, but your patient's got 0 symptoms. Now, it is extremely common out there. This is just showing you the prevalence. Take any young woman out there, 32% of them will have bacteriuria, more than 100,000 colonies per mil growing. Organisms per mil. Pregnant women, people with diabetes, institutionalized old people, dialysis patients, patients with catheters. So it is very, very common, but the patients do not have symptoms. So should you be treating these? Unfortunately, if you then look at the pus cells and you think, well, maybe the pus cells will help me. Unfortunately, pyuria in these asymptomatic patients is not an indication for antibiotic therapy. And there have been multiple randomized controlled trials that have demonstrated that if you've got 0 symptoms, but you've got bacteriuria, there is no benefit in giving antibiotics to healthy non-pregnant women, diabetic women, patients with long-term indwelling catheters, older women in the community, elderly nursing home residents, renal transplant patients, and patients undergoing orthopedic surgery. Yet, we are over-treating this group of patients. No symptoms, but we just happen to culture something on their urine. So let's look at some general principles. Only do urinalysis and urine cultures when your patient has signs or symptoms of a UTI. Don't send our urines otherwise. So don't send it just because the urine is foul smelling or cloudy. Don't send it just because you're changing a catheter. Don't do it as a fever workup if your patient has no signs and symptoms localizing to the UTI. Don't do it as a test of cure, obviously except in pregnant patients. And don't do it routinely on admission or pre-operatively. And the biggest group of surgeons that are unnecessarily sending urines are the orthopedic surgeons. I think they teach them that, as fellows, as registrars, but there was a massive study that was published in 2019 showing that you do not need to send urine for pre-operative patients unless they're having urological surgery. It's only those ones that need a urine sent. Remember, as I've just said, pyuria can be seen in many people, but it is not diagnostic of a UTI if you don't have symptoms or signs of a UTI. So if you see this on your urine report, lack of significant you won't see, it doesn't say that. It says less than 100,000 organisms, less than 10 pus cells, and nitrates negative, and you know that the patient has no signs or symptoms, all likelihood, greater than 99%, your patient does not have a UTI. A difficult one is candida in urine. So In hospital patients, about 10% of urine cultures will actually grow a Candida species, even in high numbers, greater than 100,000 colony forming units. But it doesn't mean the patient's got a UTI from a yeast. So it's a bit difficult. It's not as easy to interpret yeast cultures in urine like bacterial pathogens. It can indicate just colonization, but it can also indicate infection. It's quite rare to have a urethritis or a cystitis, but it could mean that the patient's got a candidemia and it's just the candida filtering into the urine. But if that's the case, you should actually be conducting other tests like a beta-D-glucan or blood cultures to actually assess for that. So we've noted in the literature that there is a huge amount of overtreatment of asymptomatic candiduria in hospitalized patients, especially when the doctors see, Candida auris. Oh, that's a scary bug. We have to treat it. You shouldn't be treating that different from a Candida albicans or a parapsilosis. If your patient's got no symptoms of a UTI, do not treat that Candida. So if you're going to treat asymptomatic candiduria, which is usually in admitted patients, you remove the predisposing factor. For instance, it usually means that the patient's got a catheter in. And you only treat the patient if they're at high risk for dissemination. And that's 3 groups of patients: neutropenic patients, very low birth weight infants, and patients who are going to undergo a urological manipulation. Another mistake that's being made across the board is you see a Candida auris or glabrata or whatever, and you treat with an echinocandin. Now, yes, that's fine if your patient's got a disseminated infection, but if it is a candiduria or a urinary infection, your echinocandins do not penetrate the urine. They have extensive protein binding, negligible excretion. Less than 1% of the drug that's in the system will end up in the urine. So it's not a viable option for candiduria. So if you're going to treat a Candida true urinary tract infection, your only drug of choice is amphotericin B, except if it's an albicans where you could use, fluconazole. Fluid aspirates, I see we're getting short of time, but basically lots of fluids. By the way, you can inject them into blood culture bottles. It actually preserves the integrity of the organism, especially if you're at a site that's far away from the lab. And then always remember that if you're looking for an odd organism that's not routinely culturable, like Nocardia, TB, or fungi, put that on the lab form. Pus swabs, as you can see there, microbiologists hate pus swabs. When we see pus swabs, we just see contamination, normal flora. So if you can at all avoid sending them, please avoid sending them. So superficial swabs or swabs of just pus are almost never appropriate because they are always contaminated by normal flora. And if you don't collect them properly, they are always heavily contaminated with staph, staph epidermidis and various other things. Swabs are always inferior to sending a tissue, a biopsy, or an aspirate. They shouldn't be used to guide antimicrobial therapy because they're such bad specimens. If you're swabbing a wound, you need adequate debridement or proper cleaning with sterile saline before sending those specimens. And even then we might grow colonizers. And then always state the site of the specimen on the lab form, because that lets us know what we need to be looking for in the lab, especially if there's like 20 different things growing on a plate. There is always a space for appropriate use of these swabs. So obviously screening swabs for CRE, MRSA, and VRE, nasopharyngeal swabs, obviously for viral pathogens, throat swabs for strep pyogenes, vaginal or STI swabs, and possibly burn wounds if they're adequately clean. But apart from this, we urge you out there, there's a venous stasis ulcer on a leg. Don't send a swab. We're going to grow colonizers unless you adequately clean it. So try to avoid swabs. Okay, septic markers. I see we're running out of time, so I need to go quickly. Lots of biomarkers have been proposed. Unfortunately, none of them are super sensitive and specific for infection. So it's important to note that most of these markers are helpful at ruling out an infection rather than ruling in an infection. And remember, an ESR is not a septic marker. It is recommended in some guidelines for like prosthetic joint infections, but it's not a septic marker. It's just a marker of inflammation. The most commonly sent one is CRP. It's also non-specific. It really is just a marker of inflammation, but it is cheap and it's widely available. And I suppose if it's raised in patients with signs of, that is suggestive of sepsis, it's sort of an adjunct. It supports your diagnosis. Unfortunately, it rises quite slowly. So if your patient's septic, your CRP might actually be delayed and it might only peak 48 to 72 hours later. There was a fantastic presentation done in Europe in April at ECCMID, something called the INASPOC consensus statement. And this looks at, in both adults and children's, how we use the CRP in patients that are, they look like they've got an infection. So if your CRP is between 0 and 20, all right, it could be a bacterial infection, but it's a self-limiting infection. So it's a strong recommendation, do not prescribe antibiotics. So it's not going to tell you that this is viral versus bacterial. But if your CRP is so low, it's telling you this is a self-limiting infection. You do not need to use antibiotics. If your CRP, however, is between 20 and 100, it's a bit of a gray zone, and you need to look at, risk factors. But if it's between 20 and 40, the recommendation is do not prescribe antibiotics for low-risk patients, so your otherwise healthy patients. If it's between 40 and 100, consider starting treatment with antibiotics for those patients with comorbidities that put them at increased risk of complication. So that would be this population. Or you could consider reconsulting those patients after 48 hours, or giving them a script and say, just wait, see how things go. If your CRP, however, is over 100, they say you've got a severe infection, start antibiotics, and consider hospital referral. So this was a lovely study, and you'll see the reference down here. And that might help you, especially, in the outpatient setting. In the inpatient setting, we tend to use procalcitonin. It's a much more reliable marker of sepsis. It can also distinguish between a bacterial infections. PCT levels rise within 2 to 4 hours of sepsis, unlike CRP, which is much more delayed. The kinetics also mirror the severity of the infection, and it has been useful in guiding the initiation and duration of antibiotic treatment. And if you know you're on top of the infection, your PCT levels should drop by about 50% daily as it's controlled. There are, however, other causes of a raised PCT, not common, but just for the pediatricians out there, newborns, yes, within the first 72 hours of life, you need to interpret them with caution. But after 72 hours, PCT is a fantastic measure of sepsis. As I said, there's multiple other causes, which you can, look at afterwards. I can't go through them all. So how do you use PCT in low respiratory tract infections? Well, these are the values you need to look at. If it's less than 0.1, antibiotics strongly discouraged. If it's a little bit higher, still discouraged. If it's greater than, if it's 0.26 to 0.5, antibiotics are encouraged. We also then say do an X-ray, and obviously the clinical picture must be looked at. And if it's greater than 0.5, antibiotics are encouraged. Then you monitor PCT every 1 to 2 days, all right, to support discontinuation. And then once your PCT is less than 0.25, or you've got a drop in 80% from the highest level, you can discontinue antibiotics. And this has been proven in ventilator-associated pneumonia cases, intra-abdominal infection cases. That drop of 80% will tell you you've got the infection under control, and you can discontinue antibiotics. So even 3 days of antibiotics in ventilator-associated pneumonia is effective. If you've got sepsis, so now we've got organ dysfunction, high lactates, we're talking very sick patients. The levels are a little bit different. Just so my There we go. Less than 0.5, low risk for progression to septic shock, so you don't need to start. You've got time to investigate further. 0.5 to 2, sepsis should be strongly considered, but you've got also time to still do blood cultures and x-rays. If it's greater than 2, high risk for progression to septic shock, you need to start treating urgently. And it's the same again. You monitor every 1 to 2 days with repeat PCTs. And again, if it gets down to below 0.5 compared to the one up here, or a drop in 80%, you know you're on top of the infection and you can discontinue antibiotics. Last septic marker that I just want to mention, especially for in-hospital patients, is your beta-D-glucan. It is an abundant cell wall component of many important fungi, apart from your things like your mucorales and your non-common fungi that are not typically the ones you see in the ICU. It's based upon the clotting profile of the North American horseshoe crab. I'm not going to go into details. Again, where there are some false positives, false negatives. Important to notice here, you might get false negative beta-D-glucan results with Candida parapsilosis and Candida auris. So we have noted that here in South Africa. You do also have a problem with false positives with hemodialysis patients, not so much these days with a new hemodialysis, but remember, gauzes, sponges, immunoglobulins, and some of the beta-lactams can cause a false positive. Just to note that you cannot use Fungitel to monitor fungal infections. You can't use serial ones to see, is it coming down? Oh, I can stop antifungals. You cannot do that, and it should not be used in this way. It is only validated in patients actually, with hematological malignancies and in intensive care. So this is not something you're ever going to use in an outpatient setting. It has, however, been used very successfully to diagnose pneumocystis infections, especially if you don't have PCR available to you. So in a nutshell, poor quality specimens leads to misleading results, inappropriate antimicrobial use, and a delay in the diagnosis. So the quality is always critical. And how do you interpret that? I told you, microscopy and the culture findings, and I told you how to critically evaluate your result. Remember that if it's a non-sterile site that you sent a specimen from, it could be a colonizer and not a cause of infection. So always keep that in mind. And if a patient does not respond to antibiotic therapy according to your lab results, it could mean one of these things. It's an inadequate therapy for the site of the infection. So for instance, you can't use daptomycin in a pneumonia or in a meningitis. You could have inadequate dose. You could have poor source control. You need to actually take them to theater or remove a central line. You could have resistance that's developed, or the organism on your report is not actually causing the infection. It's something completely different. So something that I think we all need to remember is that communication is critical. Now, us in the lab, we don't know the patient's clinical status, unfortunately. So in order to determine the significance of a result, you need to know how the patient's clinical picture, is in relation to the result. So our reports from the microbiology lab should encourage communication between the clinicians, the pharmacists, and the microbiologists. So I'm begging you all, if you would like to discuss your results and the significance, please phone us in the microbiology lab. We love to talk. We love to chat and communicate. So good communication makes a huge difference in patient management. You don't have to phone us necessarily. We like to WhatsApp. You can do Telegram. We can do Zooms. There's multiple formats for communication. So I implore you all to please establish that communication with your microbiology lab. And thank you so much for attending this evening.
Wow, thank you very much, Dr. Law. Dr. Law, I always call you Law.
No, that's fine.
No, it's been a great presentation. As you're going on and on and on, I say, sure, she's giving us all the information.
I know it's too much. Too much. I know. Too much.
It's not sufficient. It's not too much sufficient. Maybe just to check, will you be keen to share the slides? I see one
Absolutely. Yes,
so
no
saying,
problem. Yes,
yeah,
no problem. I will email it to you guys, and yeah, sharing is caring, and I say that the more that we learn to interpret our results properly, the better for everyone.
no, that's great. No, that's wonderful. Sure, there are a few questions already. There's one. Yeah, for those who are struggling to log to hear, it might be your speaker settings. Just check your speaker settings. I don't know how you set them up. Okay. I hear you speaking a lot about colonizing. Maybe just the concept, microbiology 101, just to say, just people understand when you speak about, when you do samples, be aware that it could be colonized. Just
Okay, all right. So as we all know, our body is not just containing, human cells. There are billions of normal flora that, colonize our body. They colonize our skin, all of our mucosal surfaces, and our GIT, our gastrointestinal tract. So anytime you send a specimen from a non-sterile site, one of those sites that's, connected to a mucosal surface, there is always the potential that what you're going to grow is just a colonizer, all right? If it's a sterile site, meaning blood, tissue, CSF, something that's a part of our body that doesn't contain organisms, if you grow something from there, it's less likely that you're going to have, you usually are going to get an organism that is significant. But remember, in order to get to that organism, you have to use a needle and perforate the skin, so you often have to go through a mucosal or skin barrier to get to those sites. And if you haven't used an aseptic technique, you can sometimes introduce those organisms, and unfortunately, then you've got colonizers on a specimen. And then, of course, you've got contaminants as well. So if you don't use aseptic technique in collecting your sample, environmental organisms can also, unfortunately, contaminate your specimens. So it's a lot to think about. But that's what I'm saying, just because you grow an organism does not necessarily mean that that is definitely causing your infection. You have to take, everything into consideration.
Thank you very much for that clarification. First question is, please comment on the treatment of polyps on CSF. The teaching has been, I think if one poly is one poly too many, to treat or not to treat.
Yeah. Absolutely. All right. Yeah. So as I said, depending on the age of the patient, the recent guidelines show that there's different values. Okay. So in an adult, all right, you can accept up to 5 polys as normal and not significant. So this is done on huge databases of patients where they've sampled CSF for multiple reasons that are unrelated to infection. So let's say a patient's got multiple sclerosis and they're doing a CSF and, they actually working how many cells are there. So they've worked out that even patients who have got no infections, up to 5 leukocytes is allowed in the CSF. In a neonate, they've got much leakier blood-brain barrier and also higher white cell counts in their bloodstream as well. So in a neonate, up to 30 cells, leukocytes in the CSF, can be considered normal. But obviously, if your picture suggests that the patient has actually got a meningitis, you're still going to investigate even within those normal barriers. And immunosuppressed patients, patients with HIV, we've seen often with TB, with cryptococcus, even with strep pneumoniae, where they've got 0 neutrophils, and yet we're growing a terribly pathogenic organism. So there's a lot of things that can affect the significance of those values.
Thank you very much. Colleagues, if you've got questions, please don't hesitate to post them on the chat box, or just raise your hand, then we'll be able to unmute you and get your question. I see you spoke about CRP and other markers. And I would have thought these are the terrain of the chemical pathologists rather than the microbiologists, or am I getting it right? We've got to.
Absolutely, Dr. Villa. You're right. But historically, you'll notice that the chemical pathologists are not the ones going out there and doing the rounds and phoning the doctors. It's as far as laboratory is concerned, it's the microbiologist that's often the face of pathology, because we go, it's not a black and white field, there's so many intricacies involved. And so we basically have adopted the training and the education to try and let doctors know about these septic markers. When they look at their screen and they just see a CRP and PCT, they're not familiar with what this patient is growing and the patient's on a ventilator or whatever. And often the microbiologist is. And so I think that's why microbiologists now are going out there and trying to educate on just the easy common septic markers, which are usually CRP and PCT. But you are correct. This is the field of the chemical pathologist, but they've tried to enable us to also try and educate physicians and doctors on their use in the correct clinical settings.
Okay, thank you very much. There's someone who asked the question, what's our calendar? This month, just trying to say, this month we were hoping to get the microbiologists, chemical pathologists, and other non-patient directly involved specialists to give talks. And so next week we're getting a radiologist also to talk about radiology presentations and how to interpret X-rays, etc. So we'll be getting that, and we'll be getting a chemical pathologist, maybe not this month, but later next month. Yeah. So we're trying to get to the different disciplines who are not necessarily on the bedside. But I'm glad that you are actually on the bedside, even as a microbiologist. You do rounds, and we invite other colleagues and to join us when you do ward rounds at the various hospitals.
Absolutely.
Yes. Okay, are there any questions? I know that there are some nurses who've joined us from infection control. Please don't hesitate to ask questions, because they also love to ask questions. I don't know if you've got any advices for IPC staff, those who are involved in infection control, and also maybe the pharmacists, and also comment about the use of antibiotics, especially that winter season.
Yes, no, absolutely. Shame. In the hospitals that I am personally involved in, which fortunately is, the clinics hospitals, I've got a very close, well, I say close, I work very closely with the IPC sisters. So always informing them about whatever is being cultured of IPC importance. And I always urge them that if they're unsure if this is an infection, is it a hospital-acquired infection, is this something significant, they know that they can call me and ask. Likewise, if there's an organism that's suddenly being cultured that alerts them to a possible outbreak, they know to phone me immediately. And it should be like that in all hospitals. There's always, in the private labs, always a pathologist or a microbiologist assigned to help you with your hospital, and get to know them. And whenever you've got an issue that you're unsure of or you don't understand, or why is this, antibiotic resistant and they're still using it, those kinds of things, phone your microbiologist, because they'll be more than willing to share with you, what is actually, the reason behind what's going on.
I suppose that advice also applies to GPs, because we also have a number of GPs who are locked in.
And GPs as well. Look, in my area, I don't work in all areas, obviously, but in my area that I actually work in, you'll see at the bottom of the microbiology reports appears the name of the pathologist, the microbiologist in your area, and a contact number. And we love to chat to you guys. I love it when my GPs phone me, because I will never, ever know the actual clinical picture of that patient. All I've got is a piece of paper and a lab result. And it's really great to be able to discuss the clinical, issues and stuff that we can't actually, write or, put on a lab report. So we urge the GPs to call us. We love the engagement. And I think it ultimately, as I said in my last slide, communication will ultimately result in much better outcomes for your patients. So I think we definitely need to communicate more and get more involved.
Okay, thank you. Yeah, I think we've covered many areas, and quite a number of people are quite happy with the presentations. And as you said, we'll share the presentations. As also people can watch on YouTube. You don't mind this presentation because it'll be live on YouTube. People can access it on YouTube
Absolutely.
too.
No, absolutely. Information needs to get out there and for everyone to share.
Yeah. Now it's all what's left is for me to thank you very much, Dr. Tinelo.
My pleasure, Dr. Bila.
To clinics and the group for being part of this webinar presentations, and it's definitely not the last time we ask you to be part of these webinars.
No, thank you very much.
It's quite a nice presentation that you had, and to thank all colleagues who logged in tonight. And I see that we had quite a large number of colleagues, more than 200 that logged in this evening. And just want to thank all of you for coming in every week, and we hope to see you again next week. And lastly, to thank Kamo from the marketing team for being with me every week to make sure that we have quality presentations, and the rest of the marketing team. Thank you very much and have a good evening. Keep warm in this cold winter time.
Thank you, everyone. Goodbye.
Bye-bye.